saying, remember, I kept getting in your way, blocking you to get to radiology. I'm like, yeah, what were you doing? So
yeah, he actually texted me. He's doing really well.
he is excelling just like we thought he would.
Yeah.
Very, very excited for him. All right, so we're going to go ahead and get started, and I'm just going to do a short introduction to get to the meat of this material. I'm always blessed to do the online CME review, and so this is a really good talk. So I don't want to take away much time from this in the very short introduction. We play such a important role in our department in the education of our medical students and our medical residents. We heard from the undergraduate medical education presentation in our last town hall meeting with Dr. Bogner, who did a just absolutely fantastic job giving us the overview of UME and the critical role we play in our department. So this is, as Brian was stating, these are ways that we can grow, and today's presentation is really a way that we become great stewards and great citizens in what we do for clinical evaluation. We have three great speakers. Dr. DeWaay really needs no introduction. So we were just catching up about her time at MUSC, and we're so lucky to have her here. Dr. McKeon from the Department of OBGYN, who is one of our outstanding educators in the College of Medicine. And then one of our young, bright superstars in Brianna Valdes in the Department of Internal Medicine, who comes from the University of Florida. And this morning at our morning residence morning report, I was joking that somehow, without me trying, we have every one of our University of Florida College of Medicine graduates, including myself in our department, who would have given grand rounds in the fall. Because we still have one more to go, and that's Stacy Bagrova, who will be giving grand rounds next week. And I did not do that on purpose. It's just one of those really interesting, cool things that came up here. So these three superstars are going to lead us through the talk that you see there, Rethinking Clinical Evaluation, from grades to growth and guided feedback. And we are blessed to have these three educational leaders here today. So I'm going to turn it over to Deb DeWaay, and I'll let her take the group in this way. Thank you guys for doing this for us today.
Well, we're thrilled to be here. I am actually going to keep my section shorter so that you can hear from the super important people. Can we go to the next slide? I do number one, we don't have any disclosures. We're educators. We were all joking yesterday that we wished we had disclosures because it would mean we have a side hustle, but we don't have any disclosures. So we'll go to the next slide. I do, while you're sort of cruising through the objectives, want to commend the department on the education you all do for our students. Everything we're going to talk about today is how to take great and make it greater, because in general, you all do a phenomenal job. Also, we have made some major changes to our evaluations, and I know you've gotten some faculty development on those, but anytime you switch up an eval, you need more faculty development, and so this is an opportunity to do that. Next slide, please. And I do want to say to all you Gators, congratulations on now being at the real #1 medical school in the state of Florida.
I will say Dr. McKeon's a Gator grad too, so we've got two on here.
I also went to Florida. Yep.
Good Lord, this is not shaped that way, but we're very proud, and we bleed USF Bulls now. Yes. So we're very proud of our roots, but we bleed USF Bulls, and amazing what this medical school's rankings are. So back to you, Deb.
So Brianna, do you want to start with the case?
Sure. I'll start us with a case. I would like you all to think back to July when you're either the senior resident, the fellow, or the attending, and your first day on service or in clinic, and this is your intern's presentation. Mr. Jones is a 65-year-old male, past medical history significant for diabetes, hypertension, coronary artery disease, status post PCI 5 years ago. Overall doing well today. He does have some intermittent chest pain, most likely costochondritis, I recommended NSAIDs. He can probably go home and follow up with his primary care doctor in 6 months. You enter the room to meet Mr. Jones, and his A1C is over 14, his LDL is over 190, he's not on any antiplatelets, has no insurance, he's A&O times 1 to 2 with crushing chest pressure. It is definitely not costochondritis, and he will not be going home today or tomorrow, and you think it is going to be a long 2 weeks. So how did we get here? How did the medical education system let this happen with this intern who's showing up on July 1? And I want to empower you to say that you can prevent this. And you'll see this guy popping up throughout our presentation with doing your evaluations. But we're going to jump off from here.
So Dreyfus and Dreyfus in the very early 80s came up with a developmental model. Some folks challenge this model in terms of exactly how it works. I am less concerned about how they think the model worked, as opposed to looking at it as a framework to really understand how our learners grow and develop. So clinical skills are very much a developmental process. So I tell the students this is not like studying for a multiple choice test. This is like learning how to read. And the reason it's like learning how to read is because you practice and you practice and you practice, and you can put lots of time in. You can have 2 students, they put the same amount of time, same amount of effort, get the same amount of feedback, and one of them is going to become an advanced beginner earlier in 3rd year, and one of them is not going to become an advanced beginner until June or July of their 4th year. So it's very much a dynamic process. Sorry, my camera's doing something funky. In addition to that, if you look at individuals, it's not linear. So they are going to go up and down. I wonder what. And our goal as educators is, as they're going up and down, can we keep them around the blue line? So we have some folks that are on the green line, and I don't know why my camera keeps freezing. Okay. And they are going to be above the curve. And then we have our folks on the red line. The goal is to identify them as early as possible. So hopefully we can do interventions to get them up to the blue line. The other big key thing that this article, I love the graphic they gave, and I think is really important when you're looking at your level of learner, is that when folks are early, they really need rules and guidelines and routines. Okay, so the more expert you get, the more that, although you're going to follow guidelines and evidence and all those things, your notes get shorter, the notes you're taking on patients get shorter, how you do things can become a little bit more holistic, you can do more things in your head. But when they're early, they really need discipline, and they need a routine, and they need to be writing things down, and they need to write things down the same way every day. So it's important as educators that knowing where your learner is along the Dreyfus model, and then helping them with routines and discipline and guidelines and rules early. And to illustrate this, I would say when you'll let your upper level resident give you a one-liner on a patient and then say, this is what the plan is for today. And in 5 sentences, the patient's presented, you go see the patient, it's fine. You would never let a 3rd-year medical student do that, because they need to do their presentations and be very systematic about things. Next slide. If you've heard me talk before, I put this slide in a lot of my talks because I think it is absolutely a crucial concept that we do not think enough about. So Frank et al. Published an article in 2010, and basically the gist of it is the educational system, instead of creating students and residents that are sort of what they think is important. They really need to provide education that creates a workforce that serves the needs of the health system. In exchange, the health system needs to provide an environment for which that training can happen. And so frequently across sort of medical education history, the education system was over here doing one thing and the health system was doing something completely different. And in an ideal world, they're working synchronously together. So one of the things that one of the big projects we have taken on, and we wanted to really let you guys know about this because we're hoping you will have seen and will continue to see a difference in the third year medical students that we're providing you in every June, is we are revamping our doctoring curriculum, and Dr. Valdes is doing a brilliant job in leading these efforts. And we have started with the end in mind. So we've looked at where students should be their fourth year as we've developed our EPAs. And we literally got a group of experts in a room on over multi-hour sessions, and we worked backwards to say, okay, if they are where we want them to be on July 1st of their intern year, where do they need to be at the end of third year, at the end of second year, at the end of first year? And we have really accelerated our doctoring training. We've done it sort of iteratively. Our current first years are a part of our rollout of the new curriculum, as I would put it. And to give you an idea on what we're aiming for, currently when our second years hit the wards, their final exam in Doctoring 2 is to do a neuropsych interactive clinical practice exam. And they've done sort of 3 exams that have the different organ systems, and they do a couple of patients, and that's it. This class, their final exam for Doctoring 2, so it won't be this academic year, but the next academic year will be a 4-station exam where they have to do 2 full H&Ps, an inpatient one, an outpatient one, and then an acute care outpatient visit and a follow-up inpatient visit. And then that way, hopefully we'll be able to target discharge summaries, calling consults, things like that, and introduction to the clerkships. So our goal is going to be to hand you a much more advanced learner at the end of, I guess it would be June 27. So stay tuned. The LCME cares about fair and timely summative assessment. So this is one, we do evaluations because that's how we measure 7 out of 8 of our program objectives. And we do this because we're good educators. And in addition to that, we are monitored on this. I do want you all to know that we were cited on this element, and we had to submit, and that was in 2023. We had to submit some follow-up documentation this past April. We are still cited on this. And the citation is based on our performance during year 3. The measurement of if we are doing this properly is student satisfaction data. So basically, if they say we're fair, then we get off the hook. If they say we're not fair, we don't. So that's a whole separate grand rounds on I'll keep my commentary on that to a minimum. Having said that, that has part of the reason we have overhauled the system, although we were probably going to do it anyway. And you will, this is just to say the IRS is watching us. And so this issue is not going to go away anytime soon. Next slide. And I will hand it over to Brianna.
So taking over where Dr. DeWaay left off, we started the overhaul on our clinical evaluations for the third year students. The way that we started this was by revamping the evaluation form. Our initial take on this form came from the University of Miami, who published a article on a new assessment tool. We took the tool that they used, which was made off of the AAMC EPAs, and we made sure that this tool is now competency-based. So the new evaluation tool that any of you have seen, if you're working with students, really came from this article here with our tweaks. So the new clerkship evaluation form, we're used to our traditional RIME framework. This talks about competency-based skills inside each of those RIME levels, if you will. So reporter, interpreter, manager, educator, they each have a specific skill set within them. This can be used for one encounter, it can be used for multiple encounters, and the difference in this form is we really went from that Likert scale of like, how good is this person, let's say 1 to 5, to what did you observe during your time with the student. This is a plug for doing your evaluations. All right. We're going to do some examples. So there should be a poll that will pop up in your chat. We'll see if it works. The first one is Susie. She is a third-year medical student rotating through your clinic. She sees 3 patients. You only are with her for 1 half day. The first patient she sees is a healthy annual exam. She presents a good head-to-toe exam. There's no acute findings. You see the patient and you agree. She moves on to patient number 2, who's here for an acute URI. She notes the patient's throat is red, no sinus tenderness, the right ear is clear. She thinks the left ear may have some bulging or redness of that tympanic membrane, but she's not sure. Overall, her most likely diagnosis is a URI. If she had to put a second thing on her differential, it would be acute otitis media. You examine the patient, you think the ears look fine, you agree with her URI diagnosis. Then she sees our third patient, who is a 3-month follow-up for diabetes and hypertension. She presents a good focused exam. She notes that they hadn't had a diabetic foot exam, so she goes ahead and does one. She looks at their feet, she feels their pulses. She doesn't do a monofilament testing and tells you she hasn't done a diabetic foot exam before, but she did go ahead and give it a go. So how would you evaluate Susie's physical exam skills today? As a reminder, our first patient was a normal annual exam. Our second patient, she presented, she said 1 tympanic membrane may have been a bit abnormal. You thought it was okay, but her differential was correct and her diagnosis was correct. And then the third patient, she attempted a diabetic foot exam, did well, but missed the monofilament testing. On her evaluation form for your half-day session, for performs a relevant and accurate examination, your options were, I had to demonstrate this to the student. My physical exam was very different from the student's exam. My physical exam was similar to the student's except for a few key items. And my physical exam matched the student's exam except for some subtle points. We'll see if a poll pops up in the chat.
It did. People have started to vote. So this is great. Technology is working. So you'll see in the chat that there is the question and there are 4 options. All you need to do is click the bubble and hit submit. We have 7 votes so far. We'll give folks another minute or so to vote.
I think people end up getting caught up between 2 answers and they say, I didn't see the student enough. We would argue that you did. You got 3 encounters with this student. So how would you fill out your form?
There's a still trickling in. We'll give another 10 seconds. But for now, we have 12 responses, 91%. So 11 of them said, my physical exam was similar to the students, except for a few key items. And 1 brave soul separated from the group and said that my physical exam matched the students, except for some subtle points.
All right. I would argue you saw the student enough to fill out this question. You didn't have to demonstrate the exam to the student. I would say your physical exam was not very different to the student. And I think this is where people get stuck. I think either answer is correct. For me in clinic, I chose that my physical exam matched the students, except for some subtle points. The reason being is that their diagnosis for patient number 2 was correct, even though they were unsure about their tympanic membrane exam. They were able to say, okay, I still think this is a URI. And then for a diabetic foot exam, they gave it a go. They did most of it. They missed one portion, and I would say that that falls in some subtle points for me. Let's do remember, I'm not asking you to grade the student. We're asking you, what did you observe? All right, let's do one that is over a 2-week rotation. So Johnny's a 3rd-year medical student on a 2-week inpatient rotation with you. He presents and writes notes for at least one patient every day. This patient's here for cellulitis. His presentations are good. You know what the general plan is for the day. Change IV to oral antibiotics, but the senior resident jumps in with details. We're going to switch ceftriaxone to Keflex for a planned 7-day course. On your first day on service, he co-signs the note directly to you. Johnny's note, you see here, he's got his hashtag cellulitis, improving, change ceftriaxone to oral antibiotics, and comments on restarting losartan. You go to attest the note, and you fix Johnny's note to say, okay, we're going to switch to the Keflex. Patient had an AKI, we're stopping the fluids. We're now restarting losartan at his half dose. By the way, he has diabetes, which is probably could be contributing to his cellulitis. We're going to continue to hold the metformin and do some sliding scale insulin while he's here. After that, you see Johnny and you say, go look at the corrections I made to your note. Now you need to co-sign your note to the senior resident first, because that was a lot for me to fix, and go from there. A week later, the senior resident is off, so Johnny co-signs his note back to you again. This time he has all the problems separated appropriately, but there's still not enough detail in the plan. So this is Johnny's new note. This patient had a PE. We're going from Lovenox to apixaban after their knee replacement per ortho, and for diabetes, he has start metformin. You update Johnny's note this time and add some details. It's a provoked PE in the setting of his knee replacement. The pharmacist is working on confirming he can afford the apixaban. We talk about some more things about the knee replacement. He's post-op day 7. We need PT/OT. Where is he going to be discharged? And he has known diabetes. We're restarting his home metformin. And then we'll discharge him with family, depending, so long as his anticoagulation is affordable and home health is set up. This time, you've been 2 weeks with Johnny. You've gotten at least 2 notes that you co-signed yourself. So you get his evaluation for accurately and cohesively documents a clinical encounter. How would you describe Johnny's documentation? I had to demonstrate this to the student. I had to rewrite most of it. I corrected a few key items. I added subtle points, but the student was nearly independent. I'm hoping there will be a poll in the chat.
There is a poll in the chat. And so again, you can bubble in your response, how you would fill out the evaluation for this student, and hit submit. And I'll let a few more folks weigh in, and then I'll read the results. Okay, we have 10 responses. 8 people said I had to rewrite most of it, and 2 people said I corrected a few key items.
Great. So I would say you had the opportunity to observe Johnny at least twice. I don't think you had to demonstrate to Johnny how to write a note, and I don't think that Johnny's note was good enough to say that I edited some subtle points, but he was nearly independent. I think I would be stuck between these 2 choices, which is what happened in our chat. I would definitely say that at the beginning, the first note on Johnny's cellulitis, I really had to rewrite most of it in order to use it as documentation. But I think by the end of the 2-week rotation, I corrected a few key items, and this is how I would have graded Johnny. So remember, the only thing the evaluation is asking of you is, what did you observe? In this particular instance, you observed 2 things. Johnny did improve. I, in this case, would lean towards Johnny's last note was usable, not great, and you had to correct a few key things, like being sure that the PE was provoked, how much did the anticoagulation cost, what's the dispo issues, but overall had the big bullets available.
I would also weigh in, this is an example of where you also want to look at the rest, like we're giving you a small piece, but you want to look at the rest of the notes, right? So if his pertinent positives and pertinent negatives are key, the history, you don't have to correct the history, you don't have to correct the physical exam, you don't have to correct the data, maybe the assessment statement is correct, then I corrected a few key items, versus if the history and the physical are wrong, then that would tip you in the other direction.
Absolutely. All right, so clinical evaluations are a problem across, not just at our institution, across multiple institutions in undergraduate medical education. At one of the AAMC Learn, Serve, Lead conferences, there was a study that was presented that only 44% of medical students believe that clerkship grading is fair. And this goes into what we've been trying to do to make grading during the third year a bit more objective and improve fairness across the clerkships. So what's been tried, we have seen that schools and the AAMC have talked about going pass-fail. We've seen some decreased student effort with this, and I find it really hard to distinguish clinically exceptional students for residency applications as someone who's reviewed them in the past when the clerkships are pass-fail. There was a study of a survey in BMC Med Ed that talked about how 89% of the program directors that were surveyed disagreed with pass-fail core clerkships and expressed concerns that the pass-fail core clerkships makes it more difficult to objectively compare residency applicants. This made them lean more on those step 2 scores and some of the other things. And then some other things that have been tried for other departments like emergency medicine is that standardized letter of evaluation. This has a descriptive area of the student, compares them to their peers, but I would argue isn't a way to get that student meaningful feedback so that we're really creating those great doctors at the end of third year. What's working so far, we have 2 of our excellent educators in the department here that have commented on some things that are going well and published on that. So comments on your evaluations that we end up using for the MSPE letters by Ledford et al. Talks about how these comments are very helpful, especially when they address specific skills, specific examples. They comment on the overarching performance of the learner, talking about Johnny from start to finish, what his note looked like at the beginning, where it was at the end, and then comparison of Johnny to his peers. And then O'Brien et al. In JGEM 2019 talks about how really getting these useful comments depends on excellent faculty development and then giving feedback to faculty on how we're doing and filling out evaluations. Throughout some of the research on this, we see 20% plus of evaluations actually are submitted without comments sometimes, and that can be really difficult. So what we're trying to do with the new evaluation form is take these comments, make them more objective, and have an added tool, which is the competency-based evaluation form, as a way to show us what the learner has been doing while you've been with them, and it really augments some of the specific comments. Let's talk about the Angoff method. So we revamped our evaluation form. It's now competency-based. So how do we decide what is a passing student, what is an honor student when we are grading them? So previously, we've talked about just in general gestalt, like many of us who have worked with learners before are like, I feel like they're an honor student. I can tell by the way that they're performing, they're an honor student, but how do we translate that into the clinical evaluation form? So the Angoff method was first described by William Angoff in 1971, and it's the standard setting method used for many medical licensing exams like ABIM. This is how, when you take your board exams, they don't just go, you know what? I think 70% on this exam should be passing. There is a method behind the madness to determine what a passing score is on that board exam. what we do when we do this is we say, what would the minimally competent physician or minimally competent student score on a particular assessment? Another way to ask with multiple choice questions is like, what percentage of minimally competent physicians would get this question correct? When we're doing our Likert scale and we're taking this out of the multiple choice world and moving it towards our clinical assessment world, what we did is we said, how would a borderline pass student score on this evaluation form or on this particular question? What's that absolute minimum acceptable passing score? So that's that student that half the time you're like, I don't know, should they pass 50-50? One preceptor's like, you know, I think they're fine. I think they're going to continue to get better. Another preceptor is like, I'm not so sure. Maybe we need some remediation. So the way that we did this with our new evaluation form is we got a group of experts in each specialty. So your group of internal medicine experts that have worked with students for years and years all got together and we went through the evaluation form question by question. So this is an example from the evaluation form. So 4 develops a prioritized differential diagnosis. I looked at our group of 5 to 10 internal medicine doctors and say, okay, you've been working with students for a long time. How would a minimally competent student score on this particular question? And each of those experts said, you know, I think that they would be a 3 or they would be a 4. We're using numbers here as opposed to the competency-based language, but they correlate with each of those competency-based statements. So let's say a 2 would be that you had to rewrite most of the note, and a 3 would be you had to rewrite, you know, you made some changes to key points. So we went question by question. For prioritized differential, identifies a unifying diagnosis, interprets common diagnostic screening tests. And then we went across here and we averaged each of those questions. So for the first question, the 2 experts here, we had a group of 6 to 10, said, okay, they both said 3, so it's a 3. For the second prompt, there's a 2 and a 3, so those average to 2.5. When you go through each of those questions, you get your expert average, and then you average the entirety of the questions on the form. And that tells you what that minimum passing score would be for that minimally competent student on the evaluation form. So instead of just saying, you know, a 2 feels like a pass, we put some evidence behind that and use our experts to create that cutoff. So what happens to your evaluation and how does this kind of apply? So after you submit your evaluation of your student, it goes to the clerkship director. And depending on what clerkship we're in and how the clerkship directors are viewing evaluations, different evals get weighted differently. For example, if you worked with the student a half day and someone worked with them for a month, the person who worked with them for a month, their evaluation could potentially be weighted more as opposed to someone's just half-day evaluation with the student. The clerkship director assigns grades not just on your evaluations, but they take into account their shelf exam, other rotation assignments, and then OSCEs if your rotation has them. So moving forward in the future, we talked now about the Angoff method and how we got this passing bar for the students. We did the same thing for honors and said, how would a minimally competent honor student score? In this particular clerkship, when the score that our experts came up with is an average of a 3.2 on the form. You can see that notated here by the star. So they said this first go around, we think the absolute minimum that an honor student would get on this form would be a 3.2. What we're going to be doing in the future is looking and saying, okay, how did that expert evaluation line up with what's actually happening in these clerkships? So here's the star with what our experts had thought. Our curriculum committee said, you know, we really think that to distinguish honor students, clinically, we usually see between 20 and 40% of the class are honors clinically over the course of the year. So that's what this blue box represents here. The absolute minimum number of honor students we think we'd have and the maximum we think we've had. Then we went back to our experts, and here was the average score that they said an honor student would have. But all the way on the left on 2.81 and all the way on the right on 3.56, when we took the lowest expert's opinion and the highest expert's opinion, that's the range that our experts thought our minimally competent honor student would score. So once we have those types of points on our graph, we can put in this black line, which is the student grades over the course of the year. This was done for the first few cohorts right after we implemented this. And we can see that where the graph intersects here, that is where, in theory, we should move our honors cutoff bar in order to meet what the curriculum committee is looking for, with 20 to 40% of students getting honors. So that's where we're moving in the future, thinking about an evidence-based way to set this honors standard, especially in clinical evaluations. We need some more data to have that actually done, but this is what we're moving from NGOF to HOSTI. All right, let's talk about some clinic preceptor pitfalls. Excuse me. So I often hear, am I going to ruin their dermatology or plastic surgery career aspirations with my evaluation? I want you to remember Mr. Jones and how you felt on July 1 when that intern presented to you. I would say no. Your job is to evaluate them, not to grade them. We just talked about how those clerkship directors are looking holistically at the student, and you're not going to change their life trajectory with your eval. Excuse me. I didn't work with the student very long. What if they're having a bad day and this is a one-off? Think about Mr. Jones. What if they weren't having a bad day? What if this wasn't a one-off? Your job's to evaluate the student, not to grade them. Every clinical interaction can be evaluated. If it was a one-off, the clerkship director is going to see that because their 10 other evals are going to reflect a better performance. Okay. What happens when our comments don't match our evaluation boxes? I think particularly in the internal medicine department, you guys do an excellent job of comments and you give really great feedback. Sometimes your feedback doesn't always land. And sometimes what I see in comments or what people say is, great job. What you meant was you worked really hard. And what the student hears is I'm exceptional. Sometimes the comments say, good presentation. What you meant was you got through your presentation. And what the student hears is I am exceptional. Sometimes you say, keep reading. What you meant, I'm honestly not really sure. I don't know if anyone really knows what you meant. What the student hears is I am exceptional because they can't think of anything else to say. And then finally, sometimes what you said is able to create assessment and plans with little supervision, which is wonderful. What you meant was you're exceptional. And what the student hears is I tried really hard. So how can we get these comments to reflect what we mean? And I think that is being sure that we're using that competency-based language and filling out the evaluations as in those bubbles as well. So instead, we want to be sure we're commenting just like Dr. Ledford and Dr. O'Brien published previously on very specific observed behaviors. And then you want to double check yourself. So do your comments support your bubbled evaluations, right? So if you wrote in your comments, this person's a rock star, they're crushing it, they're doing assessment and plans by themselves, and then you bubbled that I had to show them the physical exam, I had to rewrite their note, something's wrong, right? Either you had a really great impression of the student, which is wonderful. They were a great add to your team. You really liked being around them, but those competency skills maybe weren't necessarily there. Or when you're writing those comments, I actually think they're at the top of your form now. So you're writing those comments first, and then you're filling out your form. You really, if you're thinking they're an honor student, need to be more on the right side of that form. If you are not on the right side of that form, maybe we need to rethink and say, okay, is this student actually honors, or did they try really hard? So our goal, again, is to make really great doctors, not necessarily honor students. Right. We're going to give you some feedback phrases, because I think this is another hang up that often, sometimes at the end of a rotation, you go to fill out your eval and you're like, oof, I'm really giving some like 1s and 2s. I really had to demonstrate a lot to this student, but can I write that? I didn't tell them about it. So let's talk about how we can tell the student that they're working hard, but they need more work, or they need to improve in certain areas before we fill out the evaluation form, and what words we can use in those comments on the evaluation form to let everybody know that. That's not to keep reading and we have to read between the lines. I have often said, let's talk about a specific patient interaction. I used this last week in clinic. XYZ concerns me. Let's talk about the patient we saw in clinic. I'm worried that you said they were on all these meds, and when I walked in, they said, I don't take anything. What happened? Today I saw you tell me a Murphy sign was negative when you pushed on someone's belly while they were sitting in the chair. My goal for you is that you're doing a correct abdominal exam and getting a patient on the table and then doing a Murphy sign so that I can interpret what you tell me as definitely being true. Let's think about some ways we can get you there. Often this talks about when we had our fill-in bubbles at the bottom of your eval form versus our comments. We really want to uncouple effort and performance. I can tell you're working really hard on whatever it is. However, we still need to improve on this, this, and that. You can use those anchor statements in your evaluation to help give you feedback, right? My physical exam on this patient was very different than your exam. Let's talk about what happened. How can we fix this moving forward? And then finally, for professionalism concerns, I think it is helpful to separate the intent for perception. While I don't think it was your intent, when you show up late to clinic and have not pre-rounded, it's perceived that you don't really care about being here. So using some of these things, I think, before we submit evaluations can be helpful. And then using these in our comments to submit evaluations can be helpful. And then thinking about when we have these feelings, how are we filling out the evaluation form appropriately? I'll hand it off to Dr. McKeon.
Great. So we spent most of the bulk of this talk talking about the third year, because that is where most of our efforts have been as the Department of Medical Education over the last 18 months to 2 years. But I would say over the last 5 to 6 years, a lot of the efforts have been on how we are really preparing our fourth year students to be ready for day one of residency. And so the kind of what is the goal? Where are we trying to end up? So we hope we have convinced you, and will continue to convince you, that by giving them feedback at graduation, our medical students will be able to be exceptional interns on day one. And we have really baked that into the objectives for their fourth year. So what you're seeing here, and I will not read through them, are our specialty track phase objectives. So these are the objectives for every fourth year medical student coming through the College of Medicine for their fourth year of medical school. Next slide, please. And as you read through those, I hope they sounded somewhat familiar to you, especially for those of you who are familiar with the AAMC core EPAs. These are the final 13 core EPAs for entering residency. And really what we have done as a college is taken these 13, tweaked them a little bit, and made them our specialty track phase objectives. So essentially our fourth year curricular objectives to ensure that regardless of specialty, students are prepared to do these tasks on day one of residency. Next slide. We then took it a step further. So while we look at those tasks and we probably think those are really important tasks that people should be able to do on day one of residency, they're also pretty general and they're not very specific to perhaps the specialty that they're going to pursue. And so our goal, when we started this project back in 2018, 2019, was to identify specialty-specific EPAs that would be expected to be performed on July 1st by a new intern in that specific specialty. And so among departmental educational leadership teams, they met and had an iterative process to identify specifically what those activities would be for each subset of students, pending what residency they are pursuing. Yes, and I agree, Dr. DeWaay. Shout out to Dr. Gupta, who really started this in your department. Can you go back one slide, Dr. Valdes? Thanks.
Okay. So this refrigerator, the power keeps going out. And I noticed
I think someone needs to be muted.
Thing.
Thank you. We piloted this within 4 different specialties at USF in 2020. Yes, that was also obviously when COVID happened. And so we did it in your department. So in internal medicine, also neurology, OBGYN, and family medicine. And as of 2022 to 2023, those curricula are now expanded to 9 different specialties across both the core and select programs. And every student graduating from the College of Medicine completes a specialty-specific EPA course. Next slide. So for those of you who are less familiar with the 4th-year curriculum, this is what the 4th-year internal medicine curricular track looks like. All students take 4 weeks of an internal medicine acting internship. All students take 4 weeks of an ICU course. They then spend 8 weeks doing 2 4-week specialty selective blocks. And then their 4th-year curriculum culminates with a final assessment in the spring of their 4th year to really assess the internal medicine specialty-specific activities. Next slide. And so I, in the next 3 slides, share with you what your department has come up with, your educational leaders have come up with in terms of what are the very specific activities that we want our students pursuing internal medicine, be it both categorical or a internal medicine prelim year, to be able to do on day one of residency. And so you will see applied bacteriology. We want them to be able to order appropriate antibiotics for these common infections and disease processes. We want them to be able to triage management of infectious disease, including how to determine if someone needs to be admitted or managed as an outpatient, and how to de-escalate antibiotic therapy. Next slide. We want to ensure that they are entrustable in managing difficult conversations, specifically about being able to relay a new diagnosis to a patient and family, how to disclose a medical error, and how to give and receive feedback among their peers. We want them to be able to perform procedures, so to identify appropriate procedures, to be able to do sterile technique, to obtain informed consent, and then not necessarily to be able to do the procedures, but to be able to identify the steps for safe performance of those common procedures. Next slide. And then we want them to be able to initiate management for urgent overnight calls. So to be able to perform and receive handoffs, and to be able to triage patient encounters while on call, including phone calls and when to escalate things up to their senior residents. In terms of discharging a patient, which I think is very much within the realm of what all day one interns need to be able to do, we want them to be able to verbalize a safe discharge plan and perform all of the duties associated with discharging patients, as well as evaluate patients in discharge clinic. And yes, I will echo the shout out that I think Dr. Gupta just gave in the chat, which is that while Dr. Gupta and team helped create this curriculum, this is now being continued by Dr. Kapadia, Dr. Paz, and team. Next slide, please. So I have the privilege that in the next 5 minutes, I'm going to get to share with you all of the good work that you all have already done. And I really want to loop it back to what Dr. DeWaay said at the beginning, which is this is not you all are doing a bad job and therefore we're doing all these new things. You all are doing actually an amazing job. And in addition, we are doing these new things just to make it better. So I'm going to review 2 sets of data. And I'm going to do it in a little bit of an expeditious way because I know we're getting to the end of our time and I want to make sure there's an opportunity for questions. But the first data that we're going to review is the resident readiness survey. Next slide, please. And the second will be the graduation questionnaire. So if you're not familiar with the resident readiness survey, this is essentially a survey that's administered to program directors of students who have graduated from the College of Medicine, essentially in the spring of their intern year. And so as you can see, these are our response rates. So this was from spring of 2025. So these are students that graduated in the class of 2024. And you can see our response rate was very similar to national average. Next slide. While the data I'm going to share with you is across all graduates from the College of Medicine for which we received data, the largest chunk of the people who responded were from internal medicine GME programs. So over a quarter of internal medicine of our students that responded, the programs who responded were part of internal medicine. So I think it's a great reflection of your work. So we were slightly above national average when asked the question, did the resident meet overall performance expectations? So amazing. Next slide. In terms of professional skills, that they felt that our residents demonstrated professionalism toward other healthcare professionals and staff, toward patients and family members, that they considered their religious, educational, and other differences in interactions, and that they performed their tasks in a timely manner. The one area that I do want to note here that is highlighted in pink is slightly below national average. And this is not specific to your department. Again, this is something for all comers who graduate from the College of Medicine that we're working on, is their ability to admit their errors and accept responsibility for professional development. Next slide. In terms of their interview skills, they did excellent. They were rated as excellent in terms of physical exam, their ability to perform procedures, to prioritize a differential diagnosis, and to recognize urgent and emergent care. And I just want to kind of highlight that a lot of these things I think are due to our EPA program, because while our EPA program is very specialty specific, they really map back to these core activities. Next slide. In terms of the interpretation of basic studies and ability to understand them and the implications, our students were highly rated. They were able to use evidence and incorporate them into delivery of care. Their documentation was at national average. Their ability to write orders was slightly below national average, but still very close, as was their ability to perform an oral presentation. Next slide. And then finally, the graduation questionnaire, and this data is internal medicine specific. So next slide. For those of you who aren't familiar with the GQ, this is filled out by our graduating fourth-year medical students in the spring of their 4th year. And the national response rates are about 80%. We are slightly below that, but still with a very good response rate. Next slide. In terms of, and this is all comers, all of our graduating students who responded, overall, they are highly satisfied with the quality of their medical education. You can see that we are at actually slightly above national average, and that is both for the core and the select programs. Next slide. This is internal medicine specific. So they're asked to specifically comment on the quality of their educational experiences. This shows your trend over the last 5 years. I want to pull your attention to the dark green line. So the black line shows national average, and I want this to show you that you all have been at or above national average over the last 5 years in response to this question. So thank you, and kudos. The same trend persisted for their perception of effective faculty teaching. You all have been at or actually well above national average, and that trend has only improved as the years have gone on. So thank you. And the same thing really persists for resident education and resident teaching, so at or above national average. Next slide. So thank you for all of your hard work, and we are really appreciative. Dr. Valdes.
Yeah, and we'll just, we're going to wrap up here by saying that the standard setting that we have been implementing for the clinical evaluations is new. It's not something that we have found has really been done outside of some of our multiple choice type questions. And so we have some things pending to hopefully disseminate that to other schools. So these are some of the things that are being worked on actively. We'll take you back to our case. So turns out you did walk into the wrong room. Mr. Jones looks great. He's in his zip up because it's 50 degrees in Florida. He's dressed and ready to go. His A1C is 6. He has a statin and aspirin at home, and his primary care appointment and cardiologist are set to follow up for this week. You have a sigh of relief. Turns out it's not going to be an awful 2 weeks after all. I just wanted to leave you with rockstar interns don't just happen. Medical student growth depends on your critical feedback to make them great. And at this time, we'll take any questions.
I want to make one comment in closing. I just want to say, and this is, DeWaay opinion, nationally, we grossly underestimate what these guys are able to do. And honestly, since Medicare changed the amount of documentation, it's much better the last couple of years, but I remember when those changes first happened. And at national meetings, there is an acceptance level of medical student. Well, they're just a medical student. And I really want to continue to challenge all of us to not accept that. We are literally getting the best classes in the state of Florida. They're highly talented people. Sometimes they need a kick in the pants along with a hug of encouragement. But there's absolutely no reason these guys cannot be fantastic. And if they're not fantastic, it's really because we haven't given them the environment or the push to be fantastic. And I want you to know that is not directed at this department. You guys do give them the environment and you do absolutely give them the push, but I hope you all have noticed that there has been a great improvement in the quality of what the students have been able to do over the last few years. And I'm just really want to encourage you, don't go, oh, well, they're all fantastic now. Don't worry, I know you don't think they're all fantastic, but they're so much better. We're moving the goalpost. So continue to push them.
Yeah, excellent presentation. I will comment, I was on service for several weeks over the summer so that I had 4 brand new medical students, and they were incredible. I could not believe how prepared they were, how well they responded to feedback on presentations. The presentations already were solid, but their adjustments and the ability for them to just absolutely change in a week of feedback certainly shows all the work that has been done in the doctoring rotation. So I saw it firsthand, and I made that comment to a lot of folks of what an incredible job they're doing in doctoring, because I've never seen students, I've seen students with that fund of knowledge, but this is just presentation and some of those skills that you stated about where the patient should go as far as outpatient, ward, ICU, as well as a lot of great thought process in the history and physical and in the differential diagnosis. So I absolutely want to echo that from our department, and many in our department were stating that this year. So I want to give you that feedback. Great job, all the 3 of you and all the folks involved in doctoring courses. And I know Dr. Shiroki in our department also does an amazing work in that realm. We have
And Dr.
tons of
Sakari in year
comments.
one.
Oh, go ahead, Deb.
Both doctoring courses are led by internal medicine faculty. So Dr. Sakari in year one and Dr. Shiroki in year two, along
Absolutely.
with, and then Jen Caputo's in year three. And I'm sure I'm forgetting people. So I apologize if I'm forgetting. So
absolutely. Yes. Thank you for pointing out Dr. Caputo and Dr. Sakari. Dr. Sakari is just lined up a bunch of titles, new titles, as has Dr. Shiroki. So we have just amazing superstars. What an exciting time to be in our department and be such an active part of UME and GME. And you have comments here from Dr. Mosley, Dr. Mai, Dr. Mateja on outstanding presentation, Dr. Jackson, Dr. Gomph, and Dr. Gupta had described several of the folks in our department who've been involved with, and as well as a host of resident coaches, because that's another great point there. Dr. Mai had a question. Do you have a concise, and then we'll go to Dr. Mateja, do you have a concise statement to students regarding how their grades are derived? That was a question from Dr. Mai.
I can respond to that for those who can't see the chat. We have a very detailed explanation in their syllabus, and we've gone into great depth and detail in their syllabus to really lay it out so that it's transparent and fair. So I would direct them to their syllabus.
Perfect. Thank you. Dr. Mateja, I think you had your hands up.
Yeah, I did. Thank you. I just wanted to make a quick comment. This was fantastic. Thank you guys so much for a really wonderful presentation. And it's, music to my ears to hear that you guys do get such a wonderful response rate from our department when it comes to the student evaluations, and that you feel that the quality of the evaluation responses that you get are actually, really good too as well in comparison to probably other departments. I just want to emphasize, to guide away a little bit from UME, and just emphasize to this entire group how important the feedback still is in the GME realm too as well. We actually, across the department, do not score very well on the ACGME survey in regards to residents or fellows' satisfaction in regards to feedback. Having been the chair of my CCC now for over a decade, I will also say it's oftentimes very sparse in regards to the feedback, and the quality is also quite questionable in those regards too as well. And everything that they taught you all here applies to our advanced learners too as well. So thank you guys so much for doing a wonderful job of kind of giving these tips and tricks. And so please, please, everyone give the same deference to our GME learners as well. I would really, really appreciate that. And then also just wanted to highlight also in the chat is that Dr. Shanu Gupta had mentioned that there will be faculty development about offering written feedback evaluations. There will be a workshop on January 27th. So if you do struggle with it, there's another opportunity for great development. Thanks, everyone.
All right, looking for any other. All right, perfect. Well, in that case, we will call it a session. Great job. Thank you, Dr. DeWaay, Dr. McKeon, and Dr. Valdes. So for outstanding presentation today. And I really echo what Dr. Mateja stated, really a model for both UME and GME, and so many faculty development opportunities. It is going to be really the half decade of faculty development. It's just taking off incredible with the work of Dr. Gupta, with Dr. Quinn, and with Dr. Cuevas. And I will be doing a lot with early career, and we're already talking about mid-career physicians in that same space. So lots of exciting stuff. Well, everybody have a good day and enjoy this weather while you can still wear your jackets and sweaters outside. Take care.